So we're going to get started. Our first speaker is Chef Kashevich, everybody knows, is going to talk to us about the intraoperative management of pumps versus ECMO.
Great. It's a great opportunity for the AATS and AMSEC to work together, and the two presentations you're going to hear is one from me, and then the speaker following me is Cyril Sarek, who's the perfusionist and the head of our perfusion department at TGH. So I thought I'd talk about the choices of pump support, and Cyril will talk about the actual intraoperative management from the perfusionist point of view, but also particularly talk about the management of plasmapheresis for sensitized patients, because that's an area of challenge where pumps and transplant come together. So I am a founding partner of 3 companies that has spun out of our ex vivo lung perfusion work, and have received research support not directly related to this talk. So how do you select your pump for a lung transplant? In general, the need for intraoperative support is dictated by the patient. Usually planned intraoperative support is required for pulmonary hypertension, lobar lung transplants, and transplants where you need a cardiac repair, bypass grafts or valve or congenital heart repair. Sometimes it's not planned, but at the start of the operation you may have hemodynamic instability with decreased cardiac output or high PA pressures or hypoxia, hypercapnia. Sometimes, depending on the capabilities of the anesthesia team you happen to have that night. And then other times you get into some trouble after you've put one lung in and you get hemodynamically unstable or hypoxic, or have technical difficulties or bleeding challenges. And at the end of the operation, really with graft dysfunction, hypoxemia or hemodynamic instability. And if you look historically in our program over the last decade or so, you can see that probably about 2/3 of our transplants are done off pump and 1/3 on pump. And the other important trend you'll see is that it used to be cardiopulmonary bypass, and now we're choosing ECMO over cardiopulmonary bypass much more. In fact, if you look at just a snapshot of this period of just over a year, you can see just over 50% of our transplants were done without any support, but of the ones on support, 86 were done with ECMO and only 7 with cardiopulmonary bypass. I think it's also important when you think of the pumps for lung transplant to think of the concept of using the pump to help with lung protection. Certainly while you're implanting a lung, we keep the lung on a cooling jacket, and mechanical support has its pros and cons, but certainly when you are having troubles doing an off-pump operation, I think it's very important not to persist if you have ongoing hypoxia or hypotension. And also, once you put a lung in, you really want to give it its best chance and maintain protective ventilation of the first lung that goes in. And also, that lung doesn't have a bronchial circulation, and therefore you really want to make sure that you have ventilation and perfusion that's protective, so gentle ejection into the new lung, usually maintaining a low pressure perfusion in the range of 10 to 15 millimeters of mercury. So the advantages of cardiopulmonary bypass, of course, are familiarity. Everybody has a lot more experience with it. You can arrest the heart if you need to. You get very, very good drainage almost always, and versatility of doing what you need to do and deal with anything that comes your way. With ECMO, it's a miniaturized circuit, smaller priming volume, minimal air-blood contact, and a requirement for less anticoagulation, and you can run at ACTs of 160 to 180. So that is an advantage for lung transplantation. The disadvantages, again, cardiopulmonary bypass is the need for higher ACT and increased bleeding problems, which are a nuisance. Historically and in the literature, it's certainly associated with more primary graft dysfunction. The open venous reservoir is an air-liquid interface, plus your cardiotomy suction. You definitely have an increased systemic inflammatory response. VA ECMO, on the other hand, where it doesn't have those issues, does have a limited ability to manage air, and you have to think and operate differently. You can't really arrest the heart. The heart is sometimes incompletely decompressed, but there are ways to fix that, and we can talk about it in the discussion. And, if you do go to peripheral cannulation, you can have problems with that. And it also does require a little bit more active monitoring of fluid status and flows of the patient during the operation by you and your anesthetist and perfusionist. But if you look at ECMO versus cardiopulmonary bypass in the literature, there are now a number of centers that have reported their experience showing lower transfusion requirements, fewer reoperations, less likelihood of primary graft dysfunction grade 3, lower rate of acute renal failure, lower in-hospital mortality, survival advantage, and on the corollary, cardiopulmonary bypass is an independent risk factor for in-hospital mortality. Tiago Machuca was a fellow who trained with us, who's now in Florida, looked at our experience and showed, in the contemporary experience, showed that with ECMO we had a significantly lower length of time on the ventilator, significantly lower ICU days, and lower hospital stay, as well as a decreased rate of take-backs to the operating room for bleeding. So, and also when he looked at the survival, again, of patients, a contemporary patient set cohort in our experience, there was a survival advantage for ECMO over bypass, and clearly you can see that that advantage is really up front after the operation. So in terms of our standard technique now, we use the clamshell incision, we cannulate the aorta and the atrium. We do generally put 2 purse strings on the atrial cannulation site just to prevent, air sucking and things that are pretty automatically handled on cardiopulmonary bypass circuit that could be a problem. And we run with much lower heparin, a 5,000 unit bolus to start, and we keep get the ACT over 200 to cannulate, and then run 160 to 180 for the case. Another challenge with the circuit and the pumps is, what do you do with patients that are bridged to transplant on VV ECMO? Your choices are to just leave them on VV ECMO, but remember that the veno-venous pump does not give you significant lung protection or take the stress off the lung, and certainly doesn't give you cardiac support. But the other option is to convert to VA ECMO or cardiopulmonary bypass. So many of our patients are bridged with the dual lumen cannula. So when you bring them to the operating room, you've now got a cannulation in the neck that's outside the field. It's a little bit difficult to, keep it sterile and still prep and then get the patient on pump. So one thing we can do is you convert it to a VVA, so that you just basically wire your arterial return line and put that in the aorta, and if use the Avalon pump as your venous return and some central oxygenated return, and then you can decide at the end of the case whether to take everything out or just go back to your VV Avalon. If you were cannulated veno-venous separately, a similar concept, again, just wiring the arterial, the SVC arterial line to the aorta to give you the same concept of central support. The other thing we've done sometimes is just leave the Avalon and your ECMO circuit on the side and run it at a low rate of like 1 liter, and then just centrally cannulate, do your transplant, take your central cannulation out, and then decannulate the neck, so that you're not fussing with contaminating different circuits and trying to move them once you've draped the patient. And the similar concept again is leaving the 2 VV cannulas in and then decannulating at the end of the case. I think the other area that is changing the practice in lung transplantation is prophylactic post-op ECMO, and I've adopted this picture from a nice concept drawing that Walter Klepetko from Vienna has put forward, and really the fact that there are many ways where you can use pumps to optimize a lung for transplant, and one is ex vivo lung perfusion, the intraoperative ECMO to protect the lung, and then secondly, if you've got a problem post-op, really using prolonged ECMO over a day or two to wean the patient off again, to avoid beating up the lung on the ventilator, to really end up with a good long-term result. Prophylactic post-op ECMO centrally is pretty simple. Like, you've got the cannulas in and just bring them out through the skin, and they're already in place, and then you have to bring the patient back to open the chest, decannulate and close. You can switch the cannulas out, decannulate centrally and go to groin cannulation, but then you do add some increased risk of leg ischemia and additional cannulation sites. So again, depending on the size of the patient and the quality of the vessels, femoral vessels, you can make your decision as to which way to do it. So in conclusion, for us, VA ECMO is the preferred intra-op support for lung transplantation over cardiopulmonary bypass, unless you have a specific need for cardiopulmonary bypass to repair the heart. We're increasing in our application of ECMO for lung transplant, primarily, I think, doing sicker patients, but also with the improvements in technology and coagulation management, we're just finding it easier to use ECMO and now have a lower threshold with better results. I think there are benefits in protecting the reperfused lung, but I think more studies need to be done to say that, some people are saying, well, every transplant should now be done on ECMO because it's so good, and also the role of prophylactic ECMO. When do patients really need it? Thanks very much.